Good morning, everyone. Good afternoon, good evening, depending on where you're at. I'm very happy to be moderating this session today, where we're going to be talking about the ASH, ISTH, WFH, NHF guidelines on von Willebrand disease, diagnosis, and management. So just waiting for the next slide to come up. This is the plan for the session. I'm going to start with a couple of polling questions and then do a brief intro about the guideline process. And then I'm going to hand over to Dr. Nathan Connell, who's the clinical vice chair of both the VWD Diagnosis and Management panels. After Nathan presents, he's going to hand over to Mark Skinner, who is the past president of NHF and WFH, who will talk about the role of patients in this guideline process. And then at the end, I'm delighted that we're going to be joined by Dr. Veronica Flood and Dr. Reem Mustafa. Dr. Flood is the clinical co-chair of the VWD Management panel, and Dr. Mustafa is the methods chair for both panels. And we're all going to be present for a Q&A at the end. You should be able to see a Q&A box on your screen, and so feel free to enter in questions at any time while we're presenting, and we'll get to as many of them as we can at the end. And I also would just draw your attention to the more detailed speaker bios on the website. These are my disclosures. I have research support from Takeda, CSL Behring, and Bayer, but no direct financial relationships with pharma. So to start, we're interested in knowing who you are. Hopefully you can see the polling question up on your screen. And so we're looking for you to key in the answer. Where are you joining us from today? We are very pleased to welcome participants from all over the world, people with VWD, those who care for them, healthcare providers, and all members of the bleeding disorder community. So please go ahead and key in your answer, and I'll just wait a few more seconds before I close the poll. There's still a few more answers coming in. Great, so we can see we've got most participants from North America, but folks from Europe and South America, Asia, Africa, so welcome everyone. The role of the global community in this initiative is very important and will continue to be important as we move forward. So then our next polling question, we're interested in knowing who you are. So do you identify as a person with von Willebrand's disease? Are you someone with a bleeding disorder other than VWD, or a family member or caregiver of a person with a bleeding disorder? Hematologist, or other healthcare professional, or a researcher or scientist. So please let us know who you are. We're interested in knowing who our audience is today. And I'll just wait another couple seconds. Last few results coming in. Number of patients with us, as well as caregivers and family members, some physicians and scientists, and then a group of other participants. So welcome everybody. So just to talk about a bit of history, my involvement with this project has been going on for a number of years. Fiona Robinson and I were reminiscing from WFH that I wrote a letter on May 5th, 2015, that was a proposal to the Medical Advisory Board of WFH on behalf of the VWD and Rare Bleeding Disorders Committee about the need for a VWD guideline. And Dr. Tom Absher and Dr. Flora Pavandi were co-authors on that letter. What we realized as we started to have this discussion was that similar conversations were going on within ASH and ISTH. And we were also aware of a report that had come out in November 2014 from the National Hemophilia Foundation Strategic Summit on VWD that called for a well-qualified and authoritative organization or a consortium of such organizations should develop a new or updated evidence-based clinical practice guideline on VWD. And lastly, an international clinical VWD guideline was identified as the #1 need at the WFH International VWD Symposium in 2017. So lots of people having similar thoughts around the same time that thankfully came together. So rather than having separate projects, all of the partner organizations graciously agreed to work together. And in 2017, the project was approved. You can see a timeline on this slide. In the summer of 2018, we did a global scoping survey to identify the priorities for the guidelines, and you're going to hear more about that from Mark Skinner. We had our first in-person meetings with the panels in August of 2018. And then between August of 2018 and January 2020, an enormous amount of work, hundreds of hours of work, were performed by Dr. Mustafa and the methods team to do the systematic reviews and to put together the evidence on which we based our recommendations. And so we are now in a period of inviting public comment and are interested in hearing your thoughts today. We're going to preview a couple of the recommendations. And we are on track to have the papers published by December 2020. So with that, I'm going to hand over to Dr. Nathan Connell, the vice chair of both the diagnosis and management panels, and Nathan will briefly introduce himself and then present. Take it away, Nathan.
Thank you, Dr. James, and thank you everyone for giving us this forum to preview some of our upcoming recommendations. So my name is Nathan Connell, and I'm an adult hematologist at the Brigham and Women's Hospital in Boston and Harvard Medical School. I have no relevant disclosures related to this presentation. And today we're going to review the details of the guideline collaboration and development process, along with discussing 2 draft recommendations, along with outlining research priorities identified by the panel, as well as where do we go from here once the guidelines are published. It's important to recognize that this guideline truly is a collaboration effort that is global in its scope. And all 4 organizations that were involved in coming together have a commitment to improving the quality of life for patients with VWD. Sharing expertise and resources will ensure quality, credibility, and importantly, wide dissemination and implementation of the guidelines. And as you'll hear throughout the talk today, patient input was critical throughout the entire process. And it wasn't just by including patients as members on the panels, but asking them up front what was going to be important to them and the rest of the bleeding disorders community. Some of that work has been previously published in Hemophilia, and you'll hear about it today. And we specifically asked patients to contribute in the public comment period that Dr. James just mentioned. The objectives of the guidelines are to facilitate clinical decision-making regarding the diagnosis and management of VWD, increase access to appropriate testing and therapies, importantly, increase quality of life and health equity, identify research priorities, and also serve as a blueprint by which payers, patients, and healthcare providers and other stakeholders can focus their efforts, especially relates to advocacy and increased access to care. We had 2 panels, one for diagnosis and one for management, that included clinicians, researchers, and patients. And it's a great piece of the way that this collaboration came together, that it was geographically diverse, representing 10 countries across 4 continents. As I mentioned, there were hematologists and methods experts in addition to our patients, but we also had content experts such as pediatricians and gynecologists. There were 7 patients all across the 2 panels, diverse with respect to gender, the type of VWD diagnosis that they have, the disease severity, and their experiences. And throughout the process, there was a strict conflict of interest disclosure and management process to ensure that these guidelines were as robust as possible. The guideline development process that we used is known as GRADE, and we started with 10 to 20 clinically relevant questions generated in what you'll see is mentioned as a PICO format. Now, PICO is a specific strategy that allows the methods team to go through the published medical literature to identify a patient group of interest, an intervention such as treatment or diagnostic test, compare it to other tests or treatments, and look to see what happens to patients as a result of those interventions. The evidence summaries are generated and create a systematic review that Dr. James mentioned, and this is a standard way to try to capture all of the published evidence and research that might be available for the panel to consider. These are incorporated in frameworks that incorporate resource use, feasibility, acceptability, equity, and importantly, patient values and preferences. And it allows the panel to make recommendations based on these frameworks, so it is a very transparent process from start to finish. When the publication comes out later this year, it will have this information included of what is considered a strong versus a conditional recommendation. And this is different depending on if you're a patient or clinician. For patients, most would want the intervention if it is a strong recommendation. And for clinicians, they should think that this is where most of their patients should be getting. A conditional recommendation is more important to think about, that most people would probably want it, but there are a significant number of patients who may not want this. And that's where it goes to the clinicians for a joint decision about taking into account patient preferences and values and how the recommendation and the outcome may change. The context that we took was that of a high resource setting. And it's important to understand that while we understand that many places will not be able to actually implement these right away, this is what we might consider to be the optimal goal of care. And it allows us to have a goal to work towards in the future along all of the efforts afterwards. Patient panelists were full voting members of the panel. And I want to stress that these are draft guidelines that are still going through clarification based on comments from the public comment, and the panels still have to meet to go through all of this information and make revisions to some of the statements that you're seeing here today. So we're going to start with diagnostic thresholds. And the question that we've chosen to preview is that in patients with an abnormal initial VWD screen that may include the antigen, activity, and factor VIII, and are suspected of type 1 VWD, should the diagnosis cutoff be at a level less than essentially 30% or below the reference range of the lab, which is oftentimes about 50%? And based on the evidence, the panel has recommended a VWF level less than 30%, regardless of bleeding. And in patients with abnormal bleeding, a level less than 50% to confirm the diagnosis of type 1 VWD. And this was a strong recommendation, but it was based on low certainty in the published evidence. And when we think about this recommendation, the panel had some additional statements to make in relation to this recommendation. When we talk about VWF levels, it could be either the amount of VWF protein that's in the blood or the activity, how well it functions. Patients with levels between 30 and 50 have always been this area of debate of how we should classify their diagnosis. And we've been chatting about no abnormal bleeding should be diagnosed as low VWF. A concomitant bleeding order should be considered in patients with levels between 30 and 50%, which may contribute to the overall bleeding that a patient experiences. And if the level is not 50% in the lab, then the local lab lower levels should be used. When we considered the evidence that was available for the panel to review, there were actually 9 published studies. 4 involved mutation detection of specific changes in genes. 2 looked at the correlation between levels and someone's bleeding tendency. 4 looked at what we talked about, our likelihood ratios and odds ratios. We'll talk a little bit about that later. And 2 looked at a prospective evaluation of patients to try to understand how well the tests work in giving the correct diagnosis. When some of the information that was available from publications in 2016 showed that the lower your circulating level of von Willebrand factor in the blood, the more likely you were to have been also found to have a mutation, a genetic change that contributed. In terms of likelihood ratios, this is what I mentioned some of the studies did. This was considered by the panel, and it's a somewhat complex set of numbers to understand, but the easiest way to think about likelihood ratios are that these tell us if you have a number in that range, how likely are you to eventually be given the diagnosis of von Willebrand disease. And so, for instance, if your circulating von Willebrand factors are level is less than 20%, you are 375 times more likely to have a diagnosis of von Willebrand disease than someone with levels within the range that the lab typically says are normal. When you get to levels that are between 40 and 60%, you can see people are almost as equally likely to have von Willebrand disease or not have von Willebrand disease. And so this really takes away that very low levels are von Willebrand disease, and we need to think very carefully about the diagnosis in people with levels that are borderline. In considering these recommendations and taking the evidence as a whole, there were some themes from surveys of panel members in the discussion. And for instance, patients place a very high value on determining a diagnosis that will subsequently grant them access to treatment. The panel placed high priority on not missing cases and ensuring appropriate access to care. And we recognize that many of the treatments for VWD will benefit people with other bleeding disorders, regardless of the underlying cause. And while patients were interested in reviewing the results of their assay, they preferred clear diagnostic thresholds to provide a definitive diagnosis. What we also know is that the tests that we run continuously, and it's on a number scale. And so as you get lower, your bleeding risk increases. But we also recognize that the number isn't the only thing that contributes to somebody's bleeding experience. And so with this recommendation, the panel placed a high value on not missing the diagnosis, especially in patients who experience bleeding. And the panel also placed high value in avoiding overdiagnosis in patients who do not have bleeding. There were research priorities recognized after review of the evidence and detailed data for patients with levels between 30 and 60%, including outcomes with procedures, the prevalence of having a second bleeding disorder at the same time, and how well 30 to 60% correlates with bleeding symptoms, as well as information about family members of patients with type 1 VWD. Our next area is going to go into prophylaxis. And the management panel considered a question about patients with VWD with a history of severe and frequent bleeds. Should we use routine prophylaxis with von Willebrand factor concentrate versus no prophylaxis and just treating bleeds on demand? And the recommendation is that in patients with severe and frequent bleeds, the panel suggests using prophylaxis over no prophylaxis. And this was a conditional recommendation based on low certainty in the evidence of effects. There were 3 bodies of evidence, including a randomized controlled trial comparing prophylaxis to no prophylaxis, placebo. There were also several analyses looking at before and after patients were prescribed prophylaxis to look at outcomes. The evidence showed that routine prophylaxis reduced the risk of bleeding, improved and essentially prolonged the time to experiencing a bleeding event, reduced epistaxis, which are nosebleeds, and reduced risk of bleeding episodes, hospitalization, and heavy menstrual bleeding. In the randomized controlled trial, there was a question that there was a possibility that getting prophylaxis may actually increase the length of some of the bleeds and gastrointestinal hemorrhage. But we also recognized that the majority of these occurred in a single patient, possibly leading to overestimation. So in other words, one particular patient's experience may have skewed the results that we were seeing. Themes from surveys of the panel members and the discussion of the panelists were that patients were likely to place a high value on reducing the risk of bleeding, particularly how this affects quality of life, that value depends on the frequency and the severity of the bleeds, and this was one of those areas in which shared decision-making to review the individualized risk and benefits was going to be important, because there may be important considerations amongst patients, and since many patients are different in what they would prefer and how they would like to proceed, that not everyone would necessarily need to undergo prophylaxis. And we also recognize that making this decision is going to require educational materials regarding the potential benefits and the downsides of long-term prophylaxis. In terms of justification, there was low certainty in the evidence that using prophylaxis would be beneficial, and we understand that there are large costs associated with this benefit. What we also recognized were that long-term prophylaxis is likely to be acceptable and feasible to implement, and that by providing this, we are likely to increase health equity. The research priorities that came out of the evidence review were that we really need a large randomized controlled trial on the use of prophylaxis versus on-demand therapy, particularly looking at mucosal bleeding, and that's types of bleeding such as in the mouth and such as vaginal bleeding, for instance. Studies on the use of prophylaxis for heavy menstrual bleeding, gastrointestinal procedures, and how this impacts quality of life. And we also need studies comparing whether or not plasma-derived or recombinant von Willebrand factor concentrate would be best for prophylaxis in those that choose to proceed with prophylaxis. We also would like to know how antifibrinolytics, such as tranexamic acid, may be helpful as an adjunct to prophylaxis, and whether or not concurrent anti-angiogenic therapies may be beneficial in GI bleeding. And these are therapies that are designed to help stabilize blood vessels that are fragile. In terms of the next steps, we expect publication by the end of 2020, and that isn't the end of this guideline process. That's probably really the first hurdle for many of us, and it'll be important that once the guidelines are published, that we have to get it out there and make sure that patients and clinicians and advocates and caregivers are aware of these guidelines so that they can review this and decide what would be best to implement in terms of local practice. It's important that we have education about these new guidelines, and there is this term in guideline development called adolopment, and it's actually a combination of several different words, including adoption, adaption, and de novo development. And so we adopt these guidelines into clinical practice, but recognize that different resource settings are going to need different types of implementation efforts and tools. And we recognize that in some settings, we're going to need to consider development of a completely new guideline or research question to address it in a very specific circumstance. And so in terms of guideline dissemination strategies, the collaborating organizations will explore the development of clinical, educational, and patient-facing tools to support implementation. There's going to be a process to determine the most appropriate tools in conjunction with the chairs and the panelists. And we also recognize that the tools will need to be developed practically within the country that will be using the tool. So there's going to need to be a lot of collaboration in that effort. And so with that, I'm going to move on to some polling questions and get the audience's input. And so the first polling question is related to the diagnostic threshold. And will the recommendation on the threshold for type 1 VWD impact the lives of people with undiagnosed VWD? So please take a moment to answer this question. I see some answers coming in. If you haven't taken a moment to choose your answer and submit it yet, please do so. Okay. I'm going to go to the results. And so a number of you feel that yes, it will have considerable impact, and that perhaps it may have some impact. And there are some that are feeling that maybe this won't have much of an impact. Okay, thank you for participating in that poll. We're going to go to our next poll, and this is about the recommendation for prophylaxis. And will the recommendation on prophylaxis impact the lives of people with VWD? So just as before, please choose whether you expect it to have impact. Okay, so I'm going to switch to the results now. And it looks like a vast majority of people feel that it's going to have considerable impact. And that's what we're very excited to hear, that both of these recommendations are expected by the bleeding disorders community to have impact on the lives of people living with VWD. And so at this point, I am going to turn this over to Mark Skinner and have him talk a little bit about how we got patients involved throughout the process. Mark?
Thanks, Nathan. I am very pleased to have had the opportunity to participate on behalf of the National Hemophilia Foundation, along with my co-collaborator Ellen Riker and Fiona Robinson from the World Federation of Hemophilia. We had a organizing committee that worked throughout this process that also included representatives from ISTH, Carrie Clark and Jenny Castano. From ASH. We met monthly to make sure that the engagement was appropriate throughout the process from all of the program partners, and in particular, working to make sure that the patient voice was heard throughout. My conflict for today is I do work as a consultant for the National Hemophilia Foundation for this project in particular. And my other research funding is for studies unrelated to the von Willebrand area. So today I'm going to share 4 subjects. The first, I'm going to talk about the role of patients in guidelines in general, the role of patients on these guidelines in particular. I will share a little bit more on the scoping survey and some of the patient priorities that were in fact identified, and then the education and dissemination steps from a patient perspective that others have already alluded to. So going back to 2001, the Institutes of Medicine, now the National Academy of Sciences, published a report titled Crossing the Quality Chasm. And this really set the stage for today what is known as patient-centered care. And one of the core 6 principles is that if you're going to have quality health care, patients really need to be at the center of that. And if patients are to be at the center of this process, that means you really have to understand patient preferences, their needs, and their values if we're going to guide clinical decisions. Therefore, it really just becomes intuitive that patients need to be at the table when those decisions are being made that are going to impact their care and their individual lives. This report in 2001 was followed by another Institute of Medicine report in 2011 on what are the best practices in developing guidelines in which we all can trust. And certainly they need to be designed to optimize patient care and the outcomes for those living with the disease or condition, but they also need to include information that allows the individuals to actually assess the benefits and the harms of those decisions. And hopefully you've heard from Nathan's examples that we implemented those provisions within these guidelines, and that hopefully the guidelines that have been developed and will be published in December are guidelines in which the community as a whole can trust and that all stakeholders will have confidence in. So there were 6 core tenets of what are required to be trustworthy guidelines that were established. And the 2 that I've highlighted in white, I think are particularly relevant that it comes from the patient perspective, and that is that the panel itself be a knowledgeable panel that includes experts, but also includes representatives of the key stakeholder groups. While we have not yet published the full list of the panelists to avoid undue influence in the guideline development process, there were 3 to 4 patients, individuals, or caregivers on each of the 2 panels to offer their opinions and expertise throughout the process. And each of the guideline recommendations actually looked at the patient preferences in the development of the questions and considered whether there were subgroups that were important. And the patient panelists were able to contribute to that discussion. So what does integrating patients really mean in practicality? There's a number of areas, and there's been quite a bit of literature published on this, but I just want to highlight them because I think it really is important. As these guidelines move out into the real world, they do need to be trustworthy, as I've already mentioned. So understanding not only what caregivers and health systems think important, but understanding what the level of knowledge is, the attitudes, the expectations, the moral and ethical values and the beliefs of patients is fundamentally important if the guidelines are to have widespread use and uptake. We need to understand what the goals of patients are, individuals living with the disease, and caregivers for those that they take care of for their life and their health. What are their prior experiences living with the disease or the treatments that might be available? What are the symptoms that are most important and of concern to them? What are the undesirable outcomes that they would like to avoid? What are the desirable outcomes that they would like to achieve? And how do they think the different interventions actually might impact their quality of life? So throughout the guideline process, these elements were actually considered, and the patients provided the important voice to make sure that they were integrated. As Paula already mentioned, this work actually began back in 2014. The National Hemophilia Foundation in the US held a summit in which they identified the importance of developing guidelines and a robust scientific knowledge base for the treatment and management of hemophilia. Paula's work and that of the other collaborating organizations was moving in parallel. But subsequent to the NHF report, Paula drafted a letter to the WFH, and subsequently the 4 organizations, realizing that we each had a common interest, decided it would be most effective if we could bring 2 of the patient organizations and 2 of the medical professional organizations together to form a collaboration which really is unprecedented in the guideline development field for the diseases which we're all interested. Patient members, as I already mentioned, were a core part of the composition, and they were full voting members throughout the process. I'm going to speak a little bit more in just a moment about the international survey, but this was a fundamental piece which we found important to actually help highlight and understand the differences of what's important to patients, as well as what's important to healthcare professionals, so that we made sure the guidelines actually served all of the constituencies. We then included the patients in ranking and drafting the guidelines, and in particular, guidelines are built on what are called PICO questions. PICO stands for the populations, the interventions, the comparators, and the outcomes of interest. And in this, in particular, patients were important in identifying the outcomes that were important to them. So each guideline question, Nathan's already highlighted a couple of them, were built around what are the patient important outcomes that we're going to use to evaluate the evidence that's provided. Subsequently, training was provided. So it's not intuitive for everyone that patients should be sitting at the table and participate. And for some healthcare professionals or those that have worked in the field historically, to really know how to work with patients. Likewise, it's not always comfortable for patients to be sitting at a table and challenging individuals that they think are experts and pointing out, this is what's really important to me, and this is how it impacts my life. So training occurred not only for the patients to make sure that they were effective, but also for the healthcare professionals that were sitting around the table to make sure that they were sensitive and inclusive. And I think our methodologists did an exceptional job of making sure that throughout the process, input from all stakeholders was sought within the panel process. So we have moved on, and we've just completed the first open comment period, and I'll talk about that in just a moment, and then I will close with a little bit on the education and dissemination section. So what I wanted to highlight, and there is a publication now in Hemophilia, it came out last fall, really looking at the survey that was the pre-scoping survey that we conducted to make sure that we were prioritizing the right questions and that we included the right elements within those questions. I think this map really, and the data that I'm showing, really summarizes how broad-based it was. And for those that have worked on guidelines in the past, this level of response is really, truly amazing. Over 601 individuals actually responded. And within those responses, there were opportunities for discrete and open text comments. Over 9,500 comments were provided, which provided an enormous body of evidence for the guideline panel to know what was important and how to craft the guidelines. I think it's equally important to note that the participants were roughly split between patients and healthcare providers, so that we've really received a diverse set of comments that is well balanced. And equally important is that while often bleeding disorders are thought of as being one gender or another, we had a nice mix of men and women who participated within the process, as well as a mixture of low and high income countries. And so although the guidelines took an approach of being for a resourced country, we've had input from both throughout, as well as individuals that have received care from outside of a typical hemophilia treatment center network. So there were a few notable differences. I'll share two graphs in just a moment to break it out in detail. But this survey informed the priorities. And so within the diagnosis panel, diagnostic criteria and classifications and bleeding assessment tools were actually ranked the highest. And then screening for anemia and iron deficiency was rated the lowest. And then within the management panel, treatment options for women were rated the highest, and there was no gender difference. In fact, men also identified looking at treatment options for women as a high priority. And then treatment options for surgical patients the difference between plasma-derived and recombinant therapies among the options that were provided was rated as the lowest. So we used a 7-point Likert scale, as well as the opportunity for open comment, and then there was a threshold of significance that was identified of 0.05. So first, I want to take a look at the management results. So what you see here are patients and caregiver responses reflected in the red bars, and healthcare providers' responses are reflected in the blue bars. So there were 3 areas that reached an area of statistical significance, meaning that there was a difference between the patient and healthcare provider perspectives. The first was the use of desmopressin trials, which was rated higher by healthcare professionals than patients. The second was prophylaxis, and then the third was model of care delivery. And so the second 2 were rated higher by patients. The guidelines, and for those of you that have participated in the open comment period, you will see ended up addressing most of these areas. However, I would note that the appropriate models of care delivery was not addressed within these guidelines for a couple reasons. We thought that the guidelines ought to be established, which then could inform the model of care delivery. And because the National Hemophilia Foundation and McMaster University recently published guidelines on integrated disease management for hemophilia in 2016, that it might be appropriate as we think about an update of those guidelines to look at it holistically for all bleeding disorders. So that was not included, but it's certainly recognized and has been noted as a high priority, and hopefully will be an opportunity for subsequent work. The next area that I wanted to share was a similar graph with patients in red, healthcare providers in blue for the diagnosis topics. 4 areas had a statistically significant difference between patient and caregiver perspectives. The diagnostic journey, the diagnostic odyssey that individuals go through to receive their diagnosis was of particular importance to patients and caregivers, as you might expect, while the criteria and classifications of that diagnosis was of importance to healthcare providers. Perhaps 2 sides of the same coin, but it's important to understand the difference in perspective as you're entering into a guideline process. Laboratory cutoffs were important to the healthcare providers, and then screening for anemia was slightly higher for patients, but overall was the lowest ranking priority, as I already mentioned. So community input really was robust throughout this process, and I think it has already been demonstrated by what we saw from the scoping process, but this has continued. Within any guidelines process and within the timeline that you saw from Paula's presentation, there were a number of opportunities where the public and the community could engage. And while the guidelines themselves are a closed process for the experts, we've sought the input before and throughout the process. The 4 collaborating organizations have widely used their social media platforms and their networks to generate response and enthusiasm. We've had collaboration from our government partners, and hopefully you all have seen the social media across a wide range of platforms and seen the possibility of having input at the critical time points where it could inform. So although the open comment period has taken place, the comments are still being analyzed and will be reflected, but the opportunity for public comment is now closed. But I wanted to share with you a similar map of responses that occurred within the open comment period. So we did not have as large a number of people comment, but we had quite a robust number. And again, for those that are guideline experts, as guidelines go, having 100 people actually submit written comments is a remarkable number. We had comments from 38 countries between the 2 panels. And again, most notably, 15% of the comments that came back on the guidelines were from patients. Just for illustration, I did speak with the American Society of Hematology, who's run a number of guidelines projects recently. And in their most recent guidelines on sickle cell disease, just by way of comparison, they had only 3 to 4 patients comment per panel. And so thanks to our global community for the engagement and the participation, and hopefully the guidelines have been improved through your input. And it's no doubt to me that the knowledge that we've learned throughout has really contributed to the effectiveness and will hopefully contribute to the clarity of the final publication. But guidelines are not something that are just designed to be on the shelf. We've already highlighted this. Guidelines are something that are really intended to actually be used. So beyond publishing a nice report and series of papers, which will be coming out in December in conjunction with the ASH meeting, this really is just the first step. That the work that will occur in the development that Nathan has already described is going to be a fundamental piece. But equally important is going to make sure that the guidelines resonate with patients. Although hopefully the process has been transparent and we've demonstrated that we have met the criteria to be trustworthy guidelines, what happens once they're developed and how they move into the real world implementation will be fundamentally important. So already we have been meeting with the patient representatives that have participated in the guideline panel to try to understand from them, based on their experience, what will be required to implement these guidelines within their countries, how they can serve as tools to help advance advocacy and care, working through the national patient organizations within those countries, as well as how to make them translatable or understanding to a patient. For those that have reviewed the comments online and participated in the scoping survey, the questions can often be quite technical. And so we need to translate to make sure that the materials are actually relevant. So a few of the top line comments that we've received is there is wide interest. And so between the collaborating organizations, we're hopeful that we will have the resources to provide certainly the major language translations. The World Federation of Hemophilia's goal is typically to translate into 5 or 6 major languages. Spanish and French have been identified as particular priorities, that we need to develop plain language summaries so that they're understandable to the lay population. Individuals learn differently. Some read from text, some read from graphics, and we will try to figure out how to make them engaging and graphically representative so that they can be useful in a variety of settings, and perhaps this could help overcome some of the language barriers where we're not able to translate. We'll use communication vehicles that we've used throughout, not only the traditional clinical distribution mechanisms that ISTH and ASH and WFH uses with the healthcare professionals, but we'll be working with the patient organizations to make sure they have the tools to put it out. And that depending on the depth, that you can layer the content so that you can go deeper into the guidelines. This is an enormous body of work, and the 5 years that we spent to get to this point really is just the beginning. How we as a community use these will certainly make a difference and be the key to making a difference in patients' lives. But whatever we do, we need to help patients understand how this relates to them as individuals. Going back to the notion of this being patient-centered care, we need to make sure that patients can find themselves in the guidelines. So I did want to pay a special call out to the World Federation of Hemophilia, because this is the WFH Summit, and we have patient organizations from around the world participating in this session. The WFH is very interested in hearing from the patient organizations around the world how you would like to use these guidelines, the kind of support that you would like to receive. So I mentioned Fiona is one of the co-collaborators on the steering committee for this project. Please consider reaching out to her directly and offer your suggestions. I am confident that there will be focus groups and some other work going on over the course of the next year, but don't wait for us to ask. Please feel free to volunteer. So with that, I'm going to shift to just a couple polling questions. Feel free to be putting questions yourselves into the Q&A. We will come to those in just a moment. So the first question that I would like to ask, does knowing people with von Willebrand disease were involved in the guidelines development impact your trust in the recommendations? So we see the responses coming in, and it seems to be that there's an overwhelming answer of yes. So hopefully we have done our job well, and we've demonstrated to you that patients were certainly engaged, and that the patient voice has been heard, and the collaboration with NHF and WFH in particular contributed to that. Let's move to the results. And then moving to the next polling question, my last question. Do you think these new guidelines will impact your personal care decisions or your clinical practice? So although we've only shared a couple of them today, based on what you've seen, yes or no, or unsure. So again, perhaps we've led you to the answer that we wanted to see, but it's nice to know that we've at least communicated. And so hopefully they will have a practice and time will tell, but with your support and collaboration in the adoption and implementation, we will work together to achieve that. So at this point, I think it's time to move to the Q&A. And Paula, I turn it back over to you. Thank you.
Great, thanks, Mark. So we're going to have all of the panel members hopefully come up on screen for the Q&A. And so this is including Dr. Flood and Dr. Mustafa, as we mentioned at the beginning there. Great, I can see everybody. So we've got some great questions coming in. I'm going to start with a couple of questions about prophylaxis. So Veronica, as the pediatric representative on our panel, we've got a question about, were pediatric patients with VWD taken into account when assessing the value of prophylactic treatment?
Yes, we actually are fortunate to have had several studies that included pediatric patients. So this is one of the questions where we have data from both pediatric and adult populations. And in fact, particularly in type 3 von Willebrand disease, pediatric patients were reasonably well represented in the data. So I think that for that particular question, we can be fairly confident that the data we were able to find reflect that we are seeing similar trends in adults as we are in children.
Great, thank you. The next question is also about prophylaxis, and I'm going to direct this one to you, Nathan. Is there a specific dose that you recommend for long-term prophylaxis? Any specific recommendation for frequency? So do you want to talk about dosing and scheduling?
Sure. So I think a lot of where we go with this is based on what was used in the studies that are published. And there is some variety in what different studies use as their dosing, but probably the what we call the best quality evidence would be the randomized controlled trial that was published. And in this, these were people who were defined as having greater than 5 bleeding episodes in the last 12 months, or 3 episodes of hemarthrosis in the same joint, or 2 of several other types of bleeding. And the dose from the randomized controlled trial was 60 international units of von Willebrand factor, and it was based on ristocetin cofactor activity. So 60 units per kilogram of body weight every 3rd day. And it was rounded to the nearest pack size. And there was a slight adjustment. If patients had previous mucosal bleedings, they got that dose every other day. So 60 units per kilogram every 3rd day or every 2nd day was probably is where we have the best quality evidence at this point.
Great, thank you. So the next question I'm going to direct to both Reem and to Mark. This is a great question. We're being asked, what are the regulatory implications of these new guidelines?
Well, I can start. So you can think about the regulatory implications from different points of view. One is Nathan nicely described the implications of a strong versus a conditional recommendation for patients and for providers. But those also have implications from policy and regulatory. So strong recommendations are meant to be adapted as policies, and weak recommendations can be adapted as policies, but they do require additional consideration. I think some examples of how the panels have really given a lot of thought about the issue around access. That, for example, if there were two tests, one clearly performs better, but that is not available in different places, the panel did not choose to say, because it's not available, we're not going to recommend or suggest for it. They actually took made the decision to show that the test is better and really highlight the lack of access to the test or lack of availability of that test in certain jurisdiction, which we believed that this would support all the collaborating organizations and the advocacy groups to actually push to make sure that patients have access to the best care based on the best available evidence. And the same kind of concept applies to treatment and management and prophylaxis. So we really wanted to highlight what's the best available evidence to support management, and hopefully that will help push policy.
Thank you, Reem. Mark, do you want to comment on what you see as the regulatory impact of what we've done?
Sure, and it will vary by country. From countries such as the United States, where healthcare reimbursement and funding is a fundamental challenge, if we're looking at changes in diagnosis, laboratory tests, and access to treatments, evidence-based advocacy really is the key to advancing care. And so the guidelines will actually allow us to have a more robust set of arguments when we speak to those that are making the regulatory decisions, those that are making the reimbursement decisions, and those that are thinking about what kinds of resources should they commit. So we plan to use these guidelines really to enhance and to build out the development programs, and specifically have that body of evidence that will support advancing care for those living with von Willebrand disease.
Thanks. Thank you, Mark. I'm actually going to ask the next question, starting with you, Mark, and then I'm going to ask Reem to comment as well. So we've got a couple questions about how our patient representatives were selected. And a good question here about, given that the participants so far have been anonymous, could you please share on what basis they were selected? And then give us a sense of the regional breakdown, and did all the patients have VWD themselves?
Yeah, so that is a great question. And so it is a big world, and panels are limited in size. So we did have to make some decisions. The way the process really started was the National Hemophilia Foundation and the World Federation of Hemophilia in particular each developed a robust list of potential patients that had either previously expressed interest or that we thought had a diversity of knowledge that they could bring to the panel. The patient representatives are from multiple parts of the world, from the Asia Pacific, from Europe, from North America, and a mixture of male and female. We had both patients and caregivers of individuals with von Willebrand disease. And while I don't expect everyone will know all of the patient representatives, I do expect you will see some names from the patient community if you're involved in that area when they are published. The other criteria which was important, which does narrow the population, and this equally applied to the healthcare professionals that served, is that they needed to be minimally conflicted or conflict-free. So to the extent that patients had been involved or had direct funding, there were some criteria that everybody had to meet that did exclude individuals from participation. But they had other ways to participate, which is why the scoping survey and the open comment period were so important to us, because we knew we couldn't include everyone to actually sit on the panel. So, well, some patients wore multiple hats. We do think that we had age, gender, geographic diversity that enriched the panel.
Thanks, Mark. I agree with that completely. We've actually reached the end of our planned session. We have a lot of questions coming in, and all of our panelists are very committed to answering as many of them as we can. So if you have to move on to something else, feel free. But for those who are able to stay, we're going to stay for about another 10 minutes, and we're going to try to get through as many questions as we can. Reem, just picking up on the question we were talking about in terms of patient representation, we also have an interesting question about in comparison to other guidelines. For example, the sickle cell guideline, and what was the approach that was taken there with patients, or were those guidelines solely clinician driven? Do you want to comment on your experience with different guidelines as you've been involved with this for many diseases?
Sure. So really, sickle cell is just another example. And my experience with guideline varies quite a bit. There are guidelines which solely include the clinicians or healthcare professionals, and there are guidelines like our guidelines for von Willebrand disease, which very explicitly and really purposefully included some patients on the panel to ensure a variability of experience, a variability of phenotype, and so on and so forth. With the sickle cell, there were patients. It wasn't only clinicians. So different organizations have different philosophy and perspective about this issue. However, I have to say that this effort really with the four collaborating organizations placing very high value on making sure the patient's voice is heard was extremely valuable and enriched really by the patient's input. I do think if we think about the number of patients included on this panel was higher than many other panels I'm involved with. And the patients got quite a bit of training and a lot of support to ensure that they feel well-equipped and that they feel well-trained to know the language, to know the methodology, that they really feel comfortable speaking up, even if their opinion does not match strong voices on the panel. And it was a very collegial experience where we're all partners to make sure we get the best experience. So this is one of the examples of a true commitment to involving patients at all levels, which I think paid off.
Thanks, Reem. We've got another prophylaxis question. I think this should be quick because I think you've touched on this, but just to address the questions as they come in, about joint bleeding, Nathan and Veronica, and specific issues around prophylaxis as it relates to joint bleeding. Do either one of you want to take that?
Sure, I can take a stab at it. I think that it's important to think about patients who have the severest forms of von Willebrand disease are most likely to have joint bleeds. And so that was a population that was included in these studies. When you take the randomized control trial, for instance, the average number of joint bleeds per year was around 1 to 2 joint bleeds a year. But there was a large range, up to more than 10, for instance, in some. When you actually look at how those patients did on that study with prophylaxis, the patients that were getting it just for on-demand, there were 3 in the study. whereas in the prophylaxis group, there was only one joint bleed. So it looks to be helpful, but we're talking about very small numbers in some of these studies. So certainly, if somebody is having frequent recurrent bleeds, which, all it took was 3 episodes of hemarthrosis in the same joint to qualify for prophylaxis, there seems to be a benefit.
Thanks, Nathan. Okay, so we've got a question about, this is a great question. So the NHLBI guidelines recommend general therapy for VWF levels between 30 and 50, such as antifibrinolytics or hormonal therapy for heavy menstrual bleeding. Now that we're recommending a diagnosis of type 1 VWD in patients with levels 30 to 50 and bleeding, are we expecting specific therapy like DDABP or VWF concentrate would be considered up front for those patients? Do you want to tackle that one, Nathan, or do you want me to jump in?
I can start, and certainly having you and Veronica and Reem jump in as needed for this clinical piece. I think this is one of those very important points about getting at treating the bleeding that somebody's experiencing, and not just using a number as a cutoff to say that someone should or shouldn't have access to specific treatments. As we mentioned before, many of the treatments that we would use for VWD will work for other bleeding disorders. So clearly, if somebody's having bleeding and they have levels that are low and you don't have another specific treatment path to go down, it's something that should be considered. Again, this is one of those areas that we don't really have great data to support many of the decisions that we're trying to make. And that's why there's a specific research call for looking at outcomes in this patient population between 30 and 50%. But personally, I would say that if somebody has bleeding and they have levels in this range, treating them as VWD and even giving them the diagnosis of VWD based on what we've discussed would be completely appropriate. And I'll see Veronica and Paula, see what other comments you may have.
Yeah.
Oh, I think that was perfect, Nathan. Mark, I'm going to come back to you. We're being asked, who provided the training and support to the patient participants? Was that from WFH? Did it come from an external source? Do you want to just talk about the fairly involved process that went into this guideline project of training and supporting the patients as we moved through the various steps?
A great question and critical point. You should never put a patient at a table alone without them having the confidence and knowledge. So making sure that the patients were not alone and that we had a robust number was a first step, but that they also had time to get comfortable. So we actually had a series of webinars with the patients throughout the process, leading up to the selection of the PICO questions, as well as to the actual deliberation on the evidence tables. Both WFH and NHF provided experience and training from their individual work, from the work on the WFH management guidelines and NHF's work on the care guidelines. So we had some experience on how patients have participated and could be effective. But then Ash and Reem also identified, and we worked with an external consultant who came in and conducted an all-day training for us prior to the actual decision-making process. So the training was not just one time. It wasn't just an online curriculum. It was interactive. It was live. And we repeated it through the process, as well as provided individual opportunities for any of the patient members to discuss with the co-chairs or others what their role was and to make sure they were comfortable. So it'll be interesting, but so far the feedback has been positive from those that did participate, and we'll do a deeper debrief with them afterwards.
That's great. Thank you, Mark. So there's a question that I'm actually going to tackle here about how did the guidelines address the vital importance of the severity of bleeding symptoms not necessarily being a direct link to the questions asking about VWF type, but I think also to VWF level? And this really is a very critical issue that we considered very strongly in that recommendation that Nathan previewed about saying that we think that in an individual with bleeding and levels between 30 and 50 should be diagnosed with type 1 VWD, because we absolutely recognize that lack of clear correlation between level and bleeding, and that we want to make sure that what's happening from a diagnosis point of view is that patients who are bleeding are getting care. Nathan and Veronica, do you want to comment on that question as it relates to management?
Sure. So I think the management implication is that we want to make sure that patients are being treated for the bleeding that they have. So the guidelines are mostly set up around bleeding symptoms. And you saw that, I think, in terms of the prophylaxis question, that it wasn't restricted to people who carried a specific diagnosis, but was more set up in terms of the symptoms. So the goal is to make sure that patients are being treated for what they're presenting with and not so much focus on what their exact level is.
Thanks, that's perfect. Mark, I've got another one for you. It's about MASAC. And how is MASAC going to deal with these recommendations? How are they going to adapt these? Do you want to comment on what MASAC is and then how you see that playing out over time?
Again, a good question. And I think this would apply not only to the Medical and Scientific Advisory Council of the National Hemophilia Foundation, but also the Medical Advisory Board of the World Federation of Hemophilia or other organizations. So MASAC is the medical arm of the National Hemophilia Foundation. They issue recommendations and practice statements continuously and have a number of documents that are published on the NHF website. Steve Pipe is the chair of MASAC, and we've been in regular conversation with him throughout the guideline process. And he has committed to begin, as soon as the guidelines are published, a comprehensive review of all of the NHF guidelines and to update them as required. Not just unique to NHF, but all 4 collaborating organizations will be asked one final time prior to publication to review and sign off on the guidelines. So when the guidelines are published, they will come with the overall endorsement of NHF, ASH, ISTH, and WFH, and therefore that will set in motion for NHF's MASAC to actually begin its update process.
Thank you, Mark. Just in terms of the format here, I've been informed that we've got permission to keep going until 12:40. All of our panelists are available, and we have a few more questions to cover. So if you're available, and I can see that there are still a large number of participants on the call, so we're going to carry on for a little bit here. Reem, I'm going to ask the next question to you. We've kind of touched on this, but you may have some more specific comments to make about how this might work. Will these guidelines possibly be helpful in convincing insurance companies to possibly approve and cover the question specifically about treatments, but I think it's perhaps relevant for diagnostic tests as well?
So, that's a great question. I do think from the eyes of insurers, there are kind of different criteria that they look at, but they do very considerably look at the robustness of the evidence and the recommendations that are provided. From a payer's perspective, they want to provide best available care that is supported by evidence, but at the same time, they don't want to overpay, right? And I think that is what all of our goal is. The fact, I think the clear attention to access to care and making the connection also clear that, for example, prophylaxis or diagnosing a patient early and avoiding them having to go through a painful diagnostic journey that costs a lot of money for the payers may be the best way to go. For example, some of the questions that we addressed, the importance of specific types of testing that will help with family counseling, for example. While this may not appear as a very direct cost saving, but we try to explicitly highlight how some of those tests will actually help in the big picture and the consequences of providing the appropriate family advice in family planning that may have a saving overall. So all these things collectively, and being very explicit about resources, about acceptability, feasibility, equity, I do think will overall support patients to get access, and it will help those who advocate for patients to actually have the tools to be able to advocate, again, based on the best available evidence. And the fact that the patient's voice was on around the table will hopefully help with that process.
Thank you, Reem. So the next question I'm going to direct to Mark again. You knew you were going to be on the hot seat for most of this week, which we are very grateful for. So for prophylaxis in particular, but perhaps for all of our recommendations, how could patients be more empowered to have the healthcare providers consider patient expectations in their process of receiving care? So how could patients advocate for themselves and feel empowered? Are these guidelines going to help, or what are your general recommendations about that?
And I think that really is fundamental to the work that patient organizations do, is providing the tools for patient empowerment. It often is very difficult for a patient to raise a topic or to challenge a clinician that they might like to receive something different. In many societies, care is somewhat parental, and it's not a conversation. So in parallel with the publication of the guidelines, the World Federation of Hemophilia in particular works aggressively to help train patients how to be advocates for themselves. So part of the education and dissemination process will be putting the guidelines into lay-friendly terms and helping patients understand how they can navigate through this and see themselves in the guidelines. And then hopefully with those tools, they'll be able to go with confidence to their clinician and say, I have X symptoms, or I have X interests, and be able to talk about the evidence. And that in parallel, the clinicians will have confidence that the guidelines are built on evidence that's important to patients, and they can use this as a way to align and reach a shared decision. So the guidelines really should be viewed as empowering, but the burden is on us to help do that translation and to make sure patients can use that. But absolutely, it should be a tool that helps patients achieve access.
I appreciate that answer very much. I find it difficult when patients ask me this question because I think often we are one of the barriers there. So I appreciate your comments very much, Mark. By we, I mean healthcare providers. We've got another question about prophylaxis. So I think I'm going to ask Nathan to comment on this. What patient archetype or what kind of patient do you think would most benefit from prophylaxis? And a reasonable comment is we're a bit vague on this. And so how would you respond, and what would you say that the intention was of the management panel?
Right. I think the fact that it seems a bit vague was partially intentional, but partially maybe some area which we could do a little bit better in. And I think there are two aspects to this. The first piece about who is the ideal patient, we stated in the guideline, and we asked our methods team, as they were searching the literature, to look for patients that had severe and frequent bleeds. We didn't restrict it to a specific subtype of VWD. We didn't restrict it to a specific type of bleeding. And again, it goes back to, what were the inclusion criteria in the studies? Again, there are some that were different. The randomized controlled trial has the most data behind it, and those were patients 6 years of age or older with a diagnosis of VWD, and they had at least 5 or more bleeding episodes in the past year. So a year's worth of frequent bleeding episodes, or it could be 3 or more in a joint, or 2 or more GI hemorrhage. And so you see there's a wide variety of different types of bleeds here. This is what I put out there, that maybe this is somewhat intentional. We wanted to let the patients and their physicians make the decision jointly about, is the level of their bleeding to the point that it is severe enough to affect quality of life, and therefore consider this as part of their individualized plan. And so as we put this out for public comment, it was intentionally vague because the data are vague on it. But we got a lot of public comments back that the panel is just now receiving and processing about how to clarify this piece to make sure that we make the treatment widely available, but we do give some level of guidance above certain thresholds that really should initiate the conversation.
Thanks, Nathan. So I think because there's other sessions starting as part of the virtual meeting, we're going to wrap up. If it's possible just to get my last slide up, I want to make sure that we give the audience the email address. So if there are issues that we didn't have time to address today, or you have additional thoughts you'd like to send us on the guideline, the email address is quality@hematology.org. And I can assure you that all of the information that gets sent to that email address will be sent to the co-chairs, and we will review it carefully in light of the final publication. So thank you so much, everyone. That was a lot of fun. Thank you to my presenters and to my panelists, and thank you for all of your interest and attendance from the participants. Have a great day, everybody.